The June 6th minutes by email. A motion unless we have some discussion.
Motion
Comments?
to approve.
Second.
All in favor? Aye. Any opposed?
Hold on a minute. We had a motion to approve by Dr. Howland, a second by
Mark Tuttle.
Mark Tuttle. Okay, sorry, we have to have them for the meeting.
Would like to preface by saying that we're trying to make these meetings a little more efficient, so all the documents and things that we're going to discuss tonight, everyone should have received beforehand, and comments and concerns were requested by email. So I'd like to keep, if possible, not have lengthy discussions on every topic that we have tonight. All right, so moving on to correspondence, DOH enforcement list, ZIF, Hedrington, suspended for a year, 2 months deemed to have served concurrently with period restricted status with his employer, 10 months stayed, further pending no further violations, civil penalty $2,000, $1,500 suspended, pending no further violations for 3 years. Violation was part 800.16A13. Jean Fontes, censured, assessed civil penalty $2,000, entire amount suspended, pending no further violations for 3 years. The violation was 800.16A11. Michael Schwartzfeger, suspension deemed served concurrent, last day of employment on 10/13, ending 7/16. Civil penalty $1,000, penalty stayed pending a period of probation, placed on probation 2 years effective 7/5/16. Violations 800.16E. We have a number of correspondence. The first being New York State DOH notification that SUNY Canton received agency code for BLSFR. Correspondence indicating that University of Vermont Medical Center is looking into improving inter-hospital transport. We have a letter from SUNY Upstate Stroke Center, but I'll defer this to our guests tonight. And notification that Governor Rescue has applied to be an ambulance transfusion service. And the last is that Joshua Genter was awarded the New York State BLS Provider of the Year. Josh is from Lewis County. So congratulations to Josh. Deb has some additional correspondence that she'd like to share.
We received notification from Department of Health that North Pole received their BLSFR agency code valid and active with an update that was required, and they're good through August 31st of 2019. The same with the Depauville Fire Department through September 30th of 2019. And then a second request to complete the documentation to maintain their agency code was sent to DeFerriet Fire Department, Chameau Volunteer Fire Company, Smithville Volunteer Fire Company, Rutland, Belleville, and Calcium. So we have a second request was sent out to get those taken care of.
Okay, thank you. I'd like to introduce Jennifer and Josh, and they will be able to introduce themselves by their formal titles. They are members of SUNY's stroke telemedicine team. Nice to have you guys here.
Schleier. I'm the stroke program manager at Upstate's Comprehensive Stroke Center.
Josh Endin, I'm the outreach coordinator at Upstate. Thanks for having us.
Yes, thanks for having us. So we thought we'd come up and talk to this group. We wanted to start just by opening some discussion about telestroke, and I'm sure you've probably heard some of the work that we've been doing in the North Country.
Yes.
We started about a year ago working with some of the North Country hospitals. Since then, we have been able to go live with 4 sites in the North Country, plus Cortland Hospital, which is a bit to the south of us. So right now we are actively participating with Carthage Area Hospital. We have Samaritan Medical Center right here in Watertown. We have River Hospital in Alex Bay, Claxton Hepburn in Ogdensburg. We are working with Governor Hospital, and we'll be looking to have contracts signed in the next couple of weeks, so we'll be offering the service to them as well. We're also looking to work with Lewis County General and expect to have contracts signed with them shortly, as well as Canton Potsdam. We're still in the discussion phase with them. So essentially, this allows us to provide these area hospitals with a neurologist 24 hours a day, 7 days a week, should a patient present to that emergency department with a last known well of 0 to 6 hours and a negative head CT for hemorrhage. So those are the patients that we're looking to sort of capture with this program. There's been some discussion based on EMS bypass protocols in terms of, how to send patients to a primary stroke center versus not a stroke center in relation to telestroke. So I was looking to maybe gain some feedback from this group, and if there are any concerns related to that, we open it up for any questions or comments. No?
Everyone's quiet.
Wow, that's good.
Didn't you have a question?
Go ahead.
I think the biggest question is that I take care of anyone with your department of medical control. Is like what patients want from the scene. Who don't you want to be able to go to the global facility, and who do you think needs to go straight to construction? So if you can elaborate on that, that would be helpful.
That's sort of one of the big questions that we had out of a consult recently, and I'll give you just a little bit of background on the story for those of you that aren't familiar with it. The patient was in Clayton. We do have telestroke at River Hospital. They do stock TPA. So the question, the helicopter was called to the scene, and the patient was transported directly to upstate. So the question was, well, TPA still remains the standard of care. Should the patient have been sent by ground to River Hospital as opposed to sent by air? It's a difficult question. I think if that patient looked a little bit differently, perhaps the right answer would have been to go to River Hospital and try to get TPA. This patient had a really great outcome. There's been, there were stories in the media focused around this patient just because the system worked really, really well. Telestroke is not meant to change your area's EMS protocols. What they would have done prior to telestroke, we expect that they would have done, they would continue to do. So by rights, the patient was within 2 hours of last known well and was within an hour of air transport to our hospital, and we are the closest primary stroke center. So our position was that EMS made a good call at the scene. They called for air medical, and the patient was able to get to us, get TPA, and have a full recovery. So, we expect that EMS in the field is going to have a decision tree to make sometimes. It's not always going to be an easy call. So we'll probably rely on medical control to really be that second opinion if they're questioning.
So you can see there was a question that came from our providers, and our EMS providers are a little bit confused out there. Again, they're thinking they're making good decisions. In this case, they made a great decision. They flew this patient. The patient had a great outcome. So now they're looking for direction now that we have more patients more hospitals that have this telemed capability, because that's not addressed anywhere in your BLS protocol, and sometimes these folks are being treated by BLS providers. It's not always an ALS provider that can do that in-depth clinical assessment that an ALS provider can. So it's in front of this group for some direction for these providers. You know,
I think
should,
the providers need to involve medical control. I mean, that's what medical control is for. You call me 9 out of 10 times, I'm going to tell the provider to go to the primary stroke center rather than come to my facility. TPA isn't great. The literature's, I mean, as physicians know, the literature is terrible around TPA. The primary stroke centers have the ability to do thrombectomy and other invasive stuff, and they extend the window out to 6 hours as opposed to the TPA window, which is 3 or 4.5, depending what literature you're looking at. So I would tell the EMS providers to involve medical control.
I think that's good, solid advice, that if they're not sure whether they should go to their local hospital to get TPA, and or if they're within time limits to get them to a stroke center, then to utilize med control. So, and we are currently working on getting med control at all of our hospitals. Currently, right now, for this case, River Hospital's not set up. We're working on it to get them up and running with their medical control, so the phone call would have gone to Samaritan, probably. So.
Use med control, and I think the most important piece to this is educating the BLS and the ALS providers to know the last time of onset of symptoms. Just for appropriate utilization, it's not helpful to fly someone who was last seen 12 hours ago.
Correct.
The local facility often is the best place for that person. And so I think that's key.
And interestingly enough, there was at the state meetings, there was some discussion out of a group of stroke centers that get together, and one of the common things that they found were they weren't necessarily getting that last time of onset. So we may need to make a big push for that education.
And from the scene, from the loved one, whether they're going by ground or not.
Yeah.
And big decisions are being made at the other end, like that's the one piece of the puzzle.
And you know, you.
Anticoagulants, right?
Yeah.
That's the two big questions for you guys. Anticoagulants, maybe trauma, and then time of onset of symptoms.
Yeah, last known well is the single most important piece of information that we can get. And then, you know, we're looking for that in the exact time. We're not looking for it in, well, it was 2 hours ago. I mean, we've seen cases where everybody keeps saying, well, it was 2 hours ago. Well, meanwhile, the patient's been in the healthcare system for an hour and a half. Well, it's no longer 2 hours ago. It's now 3.5 hours ago. So the exact time is really important. Yeah, if they're on, especially the new-aged anticoagulants, you know, Coumadin, we can get an INR back and potentially give them TPA as long as it's less than 1.7. But if they've had a dose of Xarelto or, you know, any of the other ones within 48 hours, they're automatically excluded. Now, I see us being able to educate EMS providers on those exclusionary criteria a little bit down the road, and I think it needs to come a little bit at a time. You know, we're working in our area to educate them on identifying large vessel occlusion, because those are the patients that we want to send for thrombectomy. So Cincinnati Stroke Scale doesn't necessarily tell us, you know, it's positive or negative. It's just not going to tell us if it's a large vessel occlusion. So we're teaching them to go beyond that. And that's something I'd like to sort of stretch out into this area. That may help them decision tree whether or not to call a helicopter to the scene or to take them to your local hospital. But definitely, you know, using med control is the way to go.
What TP are you using for stroke care?
Alteplase?
What Alteplase? See, that's the problem. Our hospital won't stock it. We barely stock. We stock Renovase for cardiac, but Alteplase is all expensive. So our hospital pharmacy doesn't stock it.
Where are you from? I'm sorry.
Clifton Fine Hospital in Starlight.
Oh, okay.
So we're a small hospital.
Yep.
So the pharmacy isn't going to want to spend it because it'll go out of it'll be $2,000, $3,000 every other year, for perpetuity. We haven't had a stroke here yet. And I'm director of 3 EMS agencies around me. Mm-hmm. So what I might say, though, is still to come to our hospital because that's where our chopper can land and everything else.
Right.
The initial thing. I'd like to be able to do it, but we don't have the proper material. All we have is Renovase.
Well, we can certainly work with your hospital. I've been to your hospital for a visit. We can certainly look at that. The company that makes Alteplase, Genentech, will reimburse for expired product. It will also reimburse for product that is mixed and not delivered. As long as you're not doing that haphazardly and always doing that. But if your product expires, they will reimburse you. So, we know you have the equipment for telestroke
Yes.
in your hospital, and we were hoping to get some areas up and running, and then reach out to you folks to come down there and talk about it. So, we had the same situation at River. They didn't stock. I mean, we had talked with Kobe about stocking TPA on the helicopter for those patients that couldn't get to us in time, because we have had a couple of cases that by the time they came by air, they were just outside that window, and it's heartbreaking that we can't treat them. So we had talked about stocking it on the helicopter, but we deployed telestroke there, and now they stock it in the department. So we can certainly look at that. The other challenge to EMS with the rollout, our hope with this telestroke program is that we're going to see an increase in the amount of TPA utilization in the North Country. We know nationally that only about 3 to 5% of patients that are eligible get treated with TPA, and it's because they are responding to rural or community hospitals that aren't well-versed in giving it. So we want to up that utilization here in the North Country so that we get people treated that are appropriate to be treated. With that comes an interesting challenge for EMS because we obviously want to get the patients transferred to us as quickly as possible if it's appropriate that they come to us, and they can't be transported while the TPA is infusing. So TPA is administered with a 10% bolus, and then the rest of the dose is hung over an hour. So we've had a request by Carthage area ambulance service to support them and help to provide some education so that their EMS providers would be able to transport the patient with the drip infusing. We drafted a letter of support for that. We've sent it to Ann and to Dr. Delaney as well as to Carthage area hospital, and it seems, and I don't think Brett is here tonight.
So we did receive the letter, and that was the correspondence that she deferred to you. Right now, we have currently an interfacility. If they want to do an interfacility, something that's outside our protocol drugs, there's a process in place, which includes them, medical director approval, the education, ensuring everybody's educated, the request of this body to do it, etc. But currently, right now, I was advised on Monday that their medical director, they're looking for a replacement medical director because their medical director is no longer at Carthage Area Hospital.
Okay.
So that's going to put a little delay
Okay.
in the process, so, for them. And then, in general, interfacility transports are on our agenda for, as we roll out these new protocols, for potentially a different way of doing that, but the process is not complete yet.
Okay. That's fine. I think it's an interesting challenge in the North Country, and we are aware of it. Our fallback is utilizing LifeNet. What's going on there?
Nice ceiling.
Sorry.
Is just, okay. Oh, that's all right. Just utilizing LifeNet because they do have a nurse with them, so they're able to transport the patient down to us. That's most important with patients that have the large vessel occlusion, so patients that we can get in for thrombectomy, because there is a time limit to that. We recently had a patient that was coming out of Claxon. We almost exited that intervention window, and we don't want that to happen. So we're happy to do whatever it takes to work with this area to get them down as quickly as possible and help overcome any transportation challenges that we have. And we're willing to do any sort of education for any agency at any time, anything requested, from basic stroke to complex stroke. We're happy to do it.
I think we've talked about some things that we need to educate our folks on. I think if we could come up with a card that goes on people's name badges that has those critical things, so that when we call resource, we already have the answers and resources of saying, what is the time to onset? What's this, what's that? If we could have that where people could just refer to it quickly and have those answers and call resource, that we could speed up the process.
Do you have the?
We have a couple of things in place that I'd be happy to share with the group, with some things that we've been working on in central New York, helping our EMS identify large vessel occlusions and other possible stroke sites that are not a typical stroke. So we'd be happy to share that with this group and possibly disperse some.
I just think that would help with, then we're not talking to med control and tying up the airwaves and the docs, and they're saying, what about this? And then we're having to get that answer, what about that? If we can have everything, they have it at the other end, we can provide that information, then they're going to be easier for them to provide direction to the crews, and we're going to get the answers up front that are needed to determine where the patient should go.
Yeah, like a nice succinct EMS to MD report, so that can help the MD to decision tree as well. We made them little badge buddies that sort of look like this. It's a little bit bigger.
Yeah.
Has basic Cincinnati on it. Also consider, we miss posterior circulation strokes all the time because the patient presents with dizziness. Well, nobody thinks stroke when they're just dizzy, but when it's sudden onset, that's probably your diagnosis. So things like that. So we can certainly look at that and look at providing. I don't know how many providers you have in the North Country, roughly.
We can help you with that.
Yeah.
We can pull the numbers.
Yeah, we're happy to provide whatever materials you need.
Any other questions or comments for Josh or Jennifer? Thank you very much, guys, for coming.
You're welcome. Thank you for having us. We are always happy to answer any questions, so if anything comes up, please call us or let us know, email us.
Great, thank you.
You're welcome.
Okay, let's move on to old business. Jim, state EMS meetings.
You should have a copy of the minutes ahead of you. You can read it. Debbie can make some peer committee corrections for us. Go ahead, Debbie.
On your minutes under the peer committee meeting, where it says that reported that only 8 regions had submitted nominations for the state council award, that was the initial regions that had submitted. By the time all said and done, almost all of the agencies had submitted, so it was more than 80. The other thing is, in the future, we want people to start thinking now. The end of the year is December 31st. So if you know people that are worthy of a state award, you should start writing that up now and presenting it. You don't have to wait till May of next year or April for it to be in by May 1st. There may be some changes if the awards come in and the peer committee reviews the awards and they do not feel in a certain category that that award is at the state level, then they will not fill that particular award. And the concern was of routine, things becoming routine, like there are certain calls and certain things that we put people in that is fine at an agency level, but doesn't meet the caliber of a state of New York award. And that starts with the REMSCO. If people are submitted in, if we feel that as a REMSCO that they don't meet the criteria, they don't meet the eligibility, or it really isn't at the caliber of a state award, then we should not be pushing it forward. Because then the peer committee will look at it and then they won't put it forward. So we really need to start thinking that's future.
Well spoken, Debbie.
Thank you.
The only other thing that those of us that are sitting on the critical care tag, we're working hard and doing some webinars. We've been asked not to make any statements until we finished our product and recommendation to the state council. We don't want a lot of misinformation going out to the providers. So just try to respect us on the committee. We're trying to do what's best for the state as a whole and as a system. Thank you.
Does anyone have any questions for Debbie or Jim? Okay, moving on to EKG transmission, Joe and Ann. Joe?
Yes, this past summer, all the ALS squad in Jefferson County have been provided with the Surface Pro 3s and the Sierra Wireless to make their ambulance with Wi-Fi hotspots. We're looking at, Ann and I had discussed it today, moving out to St. Lawrence and Lewis counties to expand the program there. Unfortunately, nobody, to the best of my knowledge, has used it yet, but the equipment has been provided. I followed up in August with Evans Mills and Indian River, in July, Cape Vincent and Henderson. Those that already had it were Pierce, South Jeff, Todd Watertown, Black River, and Fort Drum was offered the equipment, the Fort Drum ambulance, but the government would not allow them to accept the gift. So Jefferson County is done. We're moving out shortly to Lewis and St. Lawrence. Although I don't want anybody to become ill, it would be nice to see the public and possibly make a reminder out of the this committee money. If it's appropriate.
Certainly we can do that. Thanks, Joe. Any questions for Joe? Okay, RSI. Jim?
Sure.
Mark?
We had a short meeting. It was approved by our committee and forwarded. Mark, you can take over.
Do you need me to pull any of the documents, Mark? I have them. Do you need me to put them up on the screen?
It's up to you.
Yeah.
I don't know if everybody's had a chance to see it because it was...
Right, but he may want to discuss them and have them up on the screen.
Mark, why don't you cover it since I have a sore throat?
Is the plan to like approve that draft tonight? Because I didn't get mine on email until today.
No,
Okay.
that,
'Cause
I did not get them
I haven't had a
out.
chance to read through it because I didn't
Yeah.
get it till today.
I mean, I did not get them out, so this group will make a decision whether they want to vote by email or wait till the next meeting. I would think would be the plan.
Would we like Ann to put the documents up so we can have some brief discussion?
Thought she was.
What do you want? There's 3 of them. Huh?
Yes, I thought that.
Which one?
Which one?
Project.
Policy statement.
That's a pretty fancy company you have there for your projector.
You like that?
I'm good.
Sorry, I had to look and see what was up there. Can everybody see that, or do I need to make it bigger?
Mark, do you want to speak to the document that's up there?
Basically, the long and short of it is, it's agency credentialing and provider credentialing. The requirements are on either second page of the document. And it is, the third page of the document. Active practice for 4 years with 2 years in the region. Obviously in good standing, letters of recommendations. And then the screening process is going to be a testing process with a negative code aspect, more or less, or difficult airway management aspect of it. The prerequisite for it is the difficult airway management course through the airway site or whatever it is. We're going to try and facilitate getting that up here, getting one up here locally. The re-credentialing will be annually, and there will be semester skill sessions tied in with the current CME process. Other requirements of paramedic card, BLS certification, and no previous hearing issues. Reporting of any RSI has to be 2 business days after the procedure was performed, whether successful or unsuccessful. And other than that, unless anybody has any questions, that's about the bulk of it.
Maya.
Can you show me in here, I think prior discussion spoke to the ability of an intubating service needing 2 ALS providers, both who can manage airways, not necessarily 2 paramedics, but a paramedic and an EMT, that second person being present, because I would think that that's an important piece. Is that in here?
That was not discussed.
I don't know if it
Can I
is.
make that
We had.
recommendation?
So not to RSI
Unless there's-
privileged individuals, but someone who is a second individual who is able to intubate. Is that correct? I think that's reasonable. Does anybody want to discuss that further?
Intubate or assist with ventilation?
Intubate.
That way, if the first provider misses it, you have a qualified second provider, you can switch positions, qualified second providers can stay, versus going straight to a surgical airway.
Well, what are we considering qualified provider?
No, somebody who's credentialed to intubate,
To intubate.
not necessarily RSI.
I think that's reasonable.
Discussion? We're a quiet group tonight.
I just have one question as I scanned this on my phone a little bit, is what's the basis for the requirement that you have to be practiced 2 years in the North Country EMS region? I'll use the example of my buddy Dan Clayton. He's from down Albany Country, an RSI paramedic who has years of experience, and he gets a cushy retirement cottage on the St. Lawrence and wants to volunteer with Thousand Islands Rescue. And why does he have to wait 2 years to be in this region before he could employ and be an RSI paramedic? That doesn't make sense to me.
Our thinking
I mean,
is
if
that
they-
we
if-
wanted to know the providers and know the quality of care that they provide before we potentially allow them to do something that all of us have quite, or all of we docs have quite a bit of angst.
Right. I mean, obviously, not a question for me because I obviously been here for a long time. I'm just thinking of some really good credentialed RSI paramedics that don't reside in the region.
And it might be reasonable
There might-
to consider in unusual circumstances,
Right.
Previous experience, but I don't know that we want to move forward. I mean, other comments on this, guys? This is just my opinion.
My other regional councils, that is, they similarly, Mark, have experience in the region where they'll just let people do this, and the central sub-region is 1 year. It's 2 years, 1 year, or something. I think what part of it is, there needs to be a comfort level with the provider and the hometown system before giving this skill as such as a pinnacle of how low, high risk, low frequency. Okay, I think, and that's why that's there. And then that's to become for both my central sub-region and my thinking folks. Utica has not taught this work so much differently, but it may be re-looking at it, but the moment that's what it is. I get you, but what is accepted medical practice in another region may not apply in this region, apply in this region. Depends on the whole. Even when you have combined collaborative protocols, you often sometimes expectations are in different places.
I was thinking either wording that suggests we would consider special patients, or the person can petition and ask to consider. I don't think we would turn them down if they have marked, if they have years of experience. I think we're really reasonable for it. Now, if there's someone.
I think for it to petition for may be reasonable. I don't know, other docs, comments, guys? No,
I was just going to say, so if that's the
my
case, just
opinion.
add to that sentence, extenuating circumstance or special circumstances
Such as?
could subject to exception per regional medical director.
And maybe just put in the.
What? Ken, you're shaking your head no.
I just didn't like the wording of that. Somehow or another, it's got to be the agency that's asking for these now. Somehow or another, I think it's got to be the agency that's petitioning for the relief.
Yeah.
Otherwise, you're going to have every paramedic in the
Yeah.
region. It's just Remac. So it could be an RSI paramedic.
The agency should be the guidance along with the agency medical director.
And I think we're only talking about the region experience, not the experience. So I agree. Ken, you're right. It should be the agency requesting that because they've checked this paramedic's background out and believe this paramedic has the experience and the qualifications and should be able to be vetted by the region.
Something I want to add to the committee members so they're aware of it since we last met last week is Debbie Singleton, South Jeff, has offered their mannequin for us to be trained on along with Canton and JCC. So we have 3 sites that we can, mannequins that we can use for the scenarios.
You say Canton or Claxton?
Claxton Hepburn, excuse me.
We are that close, having 3 of our providers.
We can get our training at South Jeff, and Debbie's familiar with it. So I appreciate her giving that us that opportunity.
Simulator that we can make available, and we can teach some people how to write the scenarios that you may want to use.
Really appreciate her making that available.
So we're not ready to vote on this anyways tonight,
No.
so why don't we send it back to the RSI committee to come up with some sort of, wording
Okay.
for exceptions,
I'm sorry,
and we'll bring it back.
A few additional questions.
Sure, of course.
Could an agency require a provider? Could this be a term of employment that they need to be an RSI medic?
I would say that that's up to the agency's own policies and procedures.
Yeah.
Would the region ever require, at this point, a medic to become an RSI medic?
No.
No, this is going to be a
Limited.
very selective and limited process.
Is it? Okay.
Nice.
Other comments or anything before? So how do we want to, so this will go back to the RSI committee for some sort of wording that'll then go around by email? And then we'll bring it back for a vote. When's our next meeting?
Well, currently it is January. February, excuse me. But we may have to meet prior to that because of the new protocols, so it's to be determined at this point. We have some CONs on the table that may require the REMSCO to meet prior to the end of the year, in which case, if they're going to meet, I will try to put together a Remac meeting as well, tentatively November.
Why don't we shoot for November?
Okay.
November, if everybody just kind of wants to.
Does the committee feel they can make that modification so that we can get it out to people?
Yes.
And they can look at it, and then if they have anything else, we could make Ann the funnel that you have other comments to send back that she can then share with the committee, and you can look at it and try to have it set to go.
So then for a vote in November, is everybody comfortable with that?
Yeah.
Okay, any other comments on this? Okay.
So the hospital destination, I have not had an opportunity to move forward with any of that stuff. It seems to keep getting to the back burner. My apologies to everybody. So we'll move on to the protocol review committee.
Protocol review committee.
We had a protocol committee meeting a couple weeks ago to go over the question, comment, reviews that came back. The majority of the stuff that came back was typos, which on one hand is a good thing because obviously that meant there wasn't a lot of concern about the actual protocols. Those were all forwarded on to the group that's handling the actual writing of the protocols. We discussed some questions being brought up of some ALS or critical care providers feeling that things are being taken from them, the way the questions were written. There's going to be a significant clarification, I won't call it a statement, but in the process of the rollout, there's going to be some clarifications as to what's happening and why, and how some things may be different than what we're doing. One of the greatest things that I'm going to take a moment to point out right now is there was a lot of question about facilitated innovation. The bottom line is that the material out there, the data out there, does not in any way, shape, or form support facilitated innovation. It's not good for your patients, and therefore it's significantly being reduced, pulled away. And it's also why there's quite a bit of RSI discussion. So that will be addressed further in the rollout. As far as what's going to happen with the rollout, we had a meeting down during State Council. A presentation was made on some things that are happening. Again, remember, this is a collaborative, and I'm sorry for the number. I don't remember if we're joining 11 or if by us joining it's becoming 11 regions in the state that are going to be using these protocols. And because of that, there is something called some regional exceptions or I don't want to say carve-outs, but some specifics to each region, where each region can agree that they want to modify it a little bit, but in general, the protocols will be across those regions. So one of the things that's going to happen is each region will be providing at the rollout a list of what the changes are from your current protocol to the new protocol. So the provider will actually have to read those. The provider will not have the rollout is not going to be, we're going to sit down and go through every single protocol with you. All of the providers are very intelligent. It will be up to them to read the protocols. We will go over some specific changes. There will be a few videos that are going to be done to actually show you some things. For example, the patella reduction. There's going to be a video to show you that, walk you through it, along with several other things. The intent is it's going to be done as a podcast so that you can go online and view it, listen to it. The protocol exam will be online, and it will be a rotating database so that you can't go on and take it yourself and go to your buddies and say, hey, there's for example, 27 questions. These are the answers, because the next time somebody logs in, it'll be a different set of questions. So just keep that in mind to try to keep it, as fair as possible. Remembering it is an open book test. So, you're going to have your protocols in front of you. You shouldn't have any issues. What the real destination here is, we were all hoping that we were going to be able to push for a 1/1/17 rollout of this, as in line and running. The fact is, it takes a while to take care of apps. As they sat down and explained each portion, if there's no issues or problems, we could look at the apps being completed and released about January, which means they're really looking for a spring rollout of this. Now, the statement was made, I don't know if it was tongue-in-cheek, but it was made that there is a possibility that around the end of November, if there's no glitches, we could be looking at the protocol apps being done. But then there was some giggling and chuckling, so I think it was probably really just a hopeful wish. So that being the case, we're not telling people that we're going to roll out in January. We're going to when the protocol apps are released, that's when we're going to be able to do it. With that in mind, there is also a discussion of taking our current protocol app and making it a policy statement app, so that you'll actually have a protocol app and a policy statement app. So you'll have both available right there. They are going to maintain the Apple and Droid apps. When they did the survey across all the regions, it's still maintained about 50-50. Half the people are running Apple and half of them are running Droid, so they're going to maintain both. To just give you a hint, I believe that cost, Ian, did you say it was like $9,500?
It was extremely expensive, but between, if all the regions are pitching in, it became a manageable number, so that I think we got it down to like $5,000 per region.
When you put everything together.
So each part, so just updating the protocol app, and this is only the protocol app. We have not got the price quotes for the other app, that we have for the regional policy statement yet. It has to go in a phase where they'll update the protocols, and then they'll add links in, and there's like 159, I believe is the number, links, which cost a good 10 grand to put those links in. And then there is some special things like a dosing calculator. I think it was a pediatric dosing calculator that'll cost a little extra. So we may be able to initially get the app up without the links, and then add the links and do it kind of in an incremental process until they're finally completed. But again, it does take significant time, and the only way we could afford this was, with the collaborative effort, because they are expensive to do. Hence, there probably will not be protocol books printed by the region. Of course, they will be posted as a PDF on the website. And I believe in Central New York, there may be an agency that's going to pursue having them printed more in a protocol book type. And if they do that, I believe they have agreed to share. So if folks want to purchase books to keep in their pocket, and there's many medics that are very reliable on that protocol book that they keep in their pants pocket versus the app on their phone. So, or the agency will need to print up their own protocol books.
So that was what I had. So we'll more to follow as soon as we have more information.
So there is a significant number of decisions to be made. And I think at this point, because we're going to have a November meeting, I'm going to put these questions, since we think we're going to have a November meeting, right? Because work needs to start on this, but I don't want to start work on this.
Where are you in on your CON? Yeah. Okay.
So
we have to do it within 30 days. We do November.
I am going to put these questions up here so everybody can think about this, and then we can either do an email vote if that doesn't happen, but I need answers to these questions, and our local region needs to answer.
Well, isn't the first thing we need to do is approve the protocols? Because we never voted on them.
If you'd like to do that, yes.
In our June meeting, I mean, we said we would table it, so we need to decide to join the collaborative first.
Well, we voted to move forward.
Yeah, we did.
We did, way back when, I think, but
then we had the comment period, and we said we needed to do the official vote.
I think for process, we have to do an official vote, so we'll do one, whether we need it or
That was
not.
my error. I was supposed to bring that we did discuss that in the protocol committee, that after we reviewed, and with no significant questions or comments, that the committee was going to bring it forward as a seconded motion to actually accept and go with as our formal, the collaborative protocols.
So you have a seconded motion on the floor?
We have a seconded motion. Yep. All in favor?
Aye.
Any opposed?
Thank you. We won't get in trouble by the protocol committee process. All right, so these are things to be thinking about that we need answers to. Is the region going to allow etomidate as a medical control option under procedural sedation? Are we going to allow that for paramedics if they get a medical control order? Ketorolac, are we going to make it optional for agencies and allow it in the region that we currently have it as a med control order, not it's a regional option in the new protocols. Haldol site is a regional option. Cyano kits I'd like to see made optional on the equipment list because they are extremely expensive. Ketamine is a regional option, and if an agency wants ketamine, if the region allows them to get ketamine, they have to add it to their narcotic plan and obtain the appropriate approvals. Orogastric tubes for paramedics, which we currently have, is listed as a regional option. The same as nasal, or whoops, I forgot the L, nasal-oral tracheal intubation for paramedics. See, and then I did have a question. It refers in the new protocols to a potential C2I review for use of the excited delirium or thoracic decompression protocol. Medical control requirement for RMA after diabetic wake-up and epinephrine administration for anaphylaxis. And again, these are all things in the protocol where it says refer to regional process, so I need answers to these questions, whether we want them or not. RSI, we deferred to the committee, we've already talked about. We need to develop a list of approved secondary airways, because they're referred to in the protocols. The current equipment list needs to be updated, of course, with the new meds and stuff, but one of the questions that struck me is, on our old one, we required a 3-inch decompression needle. Now the protocols are calling for greater than or equal to 3.25, and I'm not sure whether the ones that the ambulances have are 3.25 anyways.
The one for American Rescue, and the one predominantly is 3.325.
So they may be anyways, because it just said greater, I think 3-inch on, it just said 3-inch on the last one. But I almost thought, so that was kind of a question I had, that most of them are 3.25. I was going to research a little. We need to develop the regional policy statements, because there'll no longer be protocols for air medical, radio failure, deviations from protocol, transfer of care in field and at the hospital. The ROSC protocol refers to regional recommended transport time for STEMI patients, which we already going to have a STEMI protocol, so we probably just have to have a discussion on that. So there is a protocol in there that talks about BLS administering albuterol for COPD, which is not part of the BLS protocol, so we may need to look at that. And this is just a personal thing, I found that there was not nitroglycerin listed at the AEMT level for chest pain patients, but it's certainly within their scope of practice, I believe. And I think that until that can be amended in the protocols, if they're going to amend that or not, that should be part of the practice for an AEMT. Just my thoughts. So, food for thought. The sooner we get the answers, the sooner we can get some of the stuff done that needs to be done as we move forward.
Do you want to email it to the group, or is that just for the protocol committee to work on?
I can email this to the group because I think we need yes or no answers before we start doing a lot of work. I'm not going to start writing up I mean, some of it I can just do, like the policy statements. But, well, you had a comment period on the protocols.
But on the regional stuff.
Right. But again, this is all stuff I took directly out of the protocols where it says refer to regional process if the region allows.
As I mentioned, when the protocols, there are a lot of areas that talk about refer to region. So there is some regional differentials, there's some regional pull-outs, carve-outs, whatever you want to call them. So there's certain things that are come in there per your region. Just because there was a lot of different regions that had different things. That was the purpose behind that, is just to clarify what we're going to do as a region.
So I will email that out for comments.
So you thinking maybe number them and ask, once we know when we're going to have that next date, ask for people to get responses back to you like a week ahead of time so that you can compile them all in? Would that be easier for you? What do you think is going to be the easiest?
This is a protocol committee decision, what they want.
What do you want to do, Dave?
I think the idea of sending it out to the group, to the Remac group, to get their answers. I like the idea, just put a number down each one of those things. Yes, no, comment. We'll collect those back and put it together as to what we're going to do based on the return, and then get that back out to the group. That will allow us, again, because this is really looking at what our regional differences will be and how we want to handle those. So I think if we go that avenue and we just have another, we could even see what the results are, and if everything's consistent, we'll just go with that, put it together, and get the answers out to the Remac body.
Okay. Any other discussion on the protocols?
Just perhaps hold the docs. Was there anything on the list that anybody's vehemently against or has some, should go off the table? Needless and reasonable. You don't want to waste people's time if there's something it should go off the table. There's nothing for me, but I know that I would post that to the docs. This is true for all of them.
Docs? Nothing? Okay. Okay. Albuterol blood glucose policy statement. Debbie?
The albuterol and blood glucose policy statements, along with the education piece, which included the PowerPoints and the post-tests, have all been updated, and I think they were sent out to everybody. And so far, Ann had not received any comments, right?
Correct.
So do you take that as you like to?
Yes.
That's what we need to know.
So we need a motion for approval.
Motion to approve.
Seconded.
Dr. Holland and Dave, you got it?
Okay.
All in favor?
Aye.
Any opposed? Okay, provider credentialing manual. Ann?
We approved that at the last meeting. We have not yet sent it out. We were waiting for a new CME website to be up. That is, so I will get that sent out. We just, Kurt actually on Friday just finished putting the information into it. I'll talk about it more in my program agency report.
Okay, scratch rate medical director notification committee.
No report.
CME evaluators.
I'll discuss in my program agency report.
Okay. Remac operating guidelines.
Okay. The Remac operating guidelines were sent out to everybody quite some time ago. Again, I did not receive any comments back regarding these. Remember, I had talked at the last meeting, our Remac, which is a subcommittee of the REMSCO, God bless all of you, but it has grown to be as large as the REMSCO. And we've never really had a clear process of how we work things because we didn't have anybody knocking, beating down the doors to get on the REMSCO or the Remac, which I'm very pleased and thrilled to say that has changed and we have a large group of interest. So it's just also called that in order to get business done, etc., we need to put together some operating guidelines, make sure that we have a process in place, and to be able to get some work done. So, discussion on those operating guidelines. Did any? Well, never mind.
Make a motion to approve.
Seconded.
All in favor?
Aye.
Any opposed? Other old business.
If we could just briefly show people the results of the SurveyMonkey for the questions that we had developed at the last meeting, so that you can see the results. And then we will share them with a tag on the CC program for the state. But really wanted you folks to see the results first before we went outside with them. The recommendations that you gave me for changes at the last meeting, those were incorporated. And between Kurt and Ann and I, we learned how to use SurveyMonkey and how to do stuff and get it out to folks. So,
Which one do you want first?
the individual one. So I believe we sent it out to 100 and...
Hang on, I gotta remember where it is. Feel free to jump in, Kurt. Hang on a minute. Right. We did some reminders as well, too. Aha, that's what I'm looking for. So we sent out 93 total invitations. We had some bounce, but we did end up getting them. But this gives you the stats, so 79 were opened, 11 unopened, 3 bounced. I don't know where I thought we had them all taken care of.
I think it's still going to show it as bounced, because even if you fixed it so that you
Okay.
see that you did it. Yeah, because I think if you open the second one, you probably won't see any bounce.
Okay, so then we have 68 completed.
So if you could go back and we'll just go over the questions quickly, because there was only...
And this says, so we sent it initially to 93, we sent a reminder to 36 contacts that hadn't replied, and another automatic reminder went out to 27 contacts. Again, this was our first survey, we're learning, and I couldn't figure out how to put the comments in on the first time we sent it out, but we figured it out the second time, so folks understood better what we were looking for. I think we have to word our questions better on some of them, and I think that's a learning process as we move forward with the SurveyMonkey, so.
So there was question 1, how long have you been a critical care tech? And you can see the responses that we received on them.
Pretty similar to the state data as far as
And a large quantity, all except 5 of the response were actively providing care as critical carers in the region. Age, just to see where our folks fell at.
I don't think I can make that bigger. Okay, so you had, there's your 18 to 25-year-olds at top. So your largest is the 36 to 40-year-olds. Actually, it might be easier to show that than the graphs. Let me get down here to the list.
So there's our breakdown by agency of who completed the surveys. We know there's more at some of these agencies, but they didn't participate in completing the
Yeah, this
survey.
one was just what their agency was, right?
Yep.
So, it shows you that, these are all the ALS ones. Constableville doesn't have any critical care, so they just got lumped in there. This got sent to them because they came up under the ALS as an AEMT agency. If anybody has any specific questions as per their agency, I'd be happy to look it up for them. So, go ahead, Deb.
Plan on pursuing paramedic. So, can you move down to the numbers there? So, 42 said no, 26 said yes. So then we added the next question, what time frame? So you can see some in the next year, so I assume that some of those are Janine students that were CCs entering their second year. And then 1 to 2 years, there was a large quantity, and then of the quantity that they don't plan on pursuing. And if you don't plan on pursuing, why? Distance.
Distance, cost, time commitment, and other were the choices.
So the answers, do we have the comments for what people put for other?
You really want them?
Just to see if there's any, no, let's not. Let's not.
Maybe we.
So John had suggested the last one, if an advanced standing class were to be offered to bridge from a CC to a paramedic, would you be interested? And you can see we had a large quantity of yes there. So that really brought the number up of people that would pursue it. Are you in a continuing ME program to renew? Large quantity of yes, small quantity of no. So I'm not sure where they're getting their CC refresher, because we haven't offered one at Jefferson in quite a few years. I don't know if you have.
Canton does.
Lewis and Canton, maybe. So they're the folks that are entering that are doing that.
Or they don't plan on renewing. That's another. Oops.
How many calls did you respond to in 2015? You can see that we had a large quantity of people that responded to more than 150 calls. And this is the kind of data that we really need to share with the state so that they can see what kind of impact it would have on our region if the critical care program was to go away. So what's that? How many people was that in? More than 150. 28 people responded to more than 150 calls last year.
And we did also receive feedback that we should have gone larger with those categories, because many of them have provided, have gone to over 400 calls.
And year to date, targeting about the same probably for where they're going to end up the year at. And I think that was the last question, wasn't it?
Yep.
So that was our results from the, and I don't think we have all the agencies back, do we, Ian? We kind of set that out in the middle of summer, so I'm thinking that probably we are going to need to hit that one again with people to try to get the agencies to complete.
And we've sent out a couple of different reminders already with that, but
I think you're arrowing. So we only have 17 responses for the agencies completing it, and I'm sure that if it's an agency that doesn't have electronic pre-hospital care reports and they've got to manually get that data, that it's asking probably for a lot. If you can pull it data electronically, it's probably much easier. So I'm thinking that agencies that are still using manual probably are where we're not going to get the responses from. So if you could go back to your regions and your agencies in the area and encourage them to get that survey done for us, that would be greatly appreciated, because this is the kind of data that we need to share with the state so that they have the true picture for the North Country.
And just as an FYI, and this just kind of reminds me that we talked about doing the CQI and, like the use of some of these new protocols. I think that will be much easier with, now that we have SurveyMonkey, some of it can be done that way if we get our agencies to start responding. And I would venture to say that if they remain unresponsive to our office for data request and quality assurance stuff, that we move forward with looking at those agencies and their level of care.
Anyone have any comments or questions for Debbie or Ann? Okay, any other old business? Okay, program agency report.
Just tell me if that's not showing up, okay, because I'm not looking at it. All right, so just basically we did it, we completed the fourth quarter. I've been back for a year now as of July 6th. Our quarter ended June 30th. We've got the process down pat. I am very pleased to say that we are now receiving our payments 5 to 7 days after we voucher. We just received a new voucher for future remittance. We worked with SUNY Canton. They obtained a new BLSFR code. As you know, we had the correspondence. We as in Kurt, spent a long time cross-referencing all charts to state database and worked with state to correct multiple discrepancies regarding Remac approved modalities such as epi-albuterol or blood glucose, all those things we report on. Under our program agency website, you'll see a CON selection added under the Remsco Remac link. This, I am guessing that when we are ready to do a CON is where you will find the CON posted. But we also, for the general public, we put out the timeline that we use for CONs, links to the policy statements and pricing. As I said, we transitioned to a new online CME website that's been a work in progress for quite a while. It has more functionality. It incorporates information that we previously kept in a separate agency database, so it's going to allow us to keep more data in one area instead of multiple databases like we had. And as I said, Kurt had just finished moving some of the agency data over there. We were forgetting to update in one or the other ones, and just too many databases. So this is great. Hopefully we'll be able to track some more online education through this. And on this website, I would like to put the blood glucometry and the albuterol trainings so that BLS providers can register, and for agencies who have BLS approved, agencies who are approved for these modalities, that will allow them to educate their providers, which we have an obligation to ensure that they have all that education. And we have rosters and folks who've educated, but it's very difficult for the agency sometimes to get new providers updated on this stuff. So I'd like to make those online trainings.
You need that form of a motion?
I would second it.
I make the motion that whatever Ann wants to put online, let her do it.
I won't go that far.
Training modules.
A training module that could be interpreted a wrong way too.
I would secondly say that we move forward in trying to, one of the requirements is annual training. Now that we have the ability to track this, and it is really our obligation for these modalities such as CPAP, blood glucometry, albuterol, not epi, but albuterol, that we start working just as we did with the ALS to get all BLS providers online and eventually work towards ensuring that this is done on an annual basis for BLS providers. So I know Central New York does require skills for their BLS providers. We've always shied away from that here in the North Country because I will tell you, prior to this system, nightmare city trying to track it. But with this system, it can be tracked, and I think it would be very beneficial. It'll be beneficial for our providers to have this training and beneficial for our agency leadership to be able to have some of this training and stuff online. That's my thoughts. So we had a motion, did we?
Did I
I think
make a
there's a
motion?
second, too. Steve, you seconded. All in favor? Any opposed?
We used to track the basics.
I have the check and inject program on here. We assisted Melrems in reminding agencies to send their pre and post test tax exempt forms, and in some cases their order forms for the check and inject program. And I have this at the end slide too, so I'll go over some of the data and what the recent state decision was in regards to that program. And that's for, if everybody remembers, the BLS providers drawing up with a special syringe, epinephrine out of a vial versus buying an auto injector that cost a lot of money. So the opioid overdose program that we're operating, we've given out approximately 200 Narcan kits, and we've done some reports to the state. More have been ordered, but my understanding is Suffolk County ordered 2,000, so we're waiting. CME evaluators, we really need to discuss CME evaluators. So currently right now, I have, in this discussion does not surround these two providers, I just happen to have applications for these two providers sitting on my desk. James McGrath of Norfolk also works at Messina Rescue, and Patrick Vincent from Lewis County Search and Rescue. One of the things that I've discovered is I'm going out there doing ALS inspections, and we've talked about it before, but sadly, there is a lot of pencil whipping going on, and folks are not doing their skills. They're just being signed off by evaluators. We need to look at our CME evaluator process. I did pass it by the REMSCO Executive Committee a little bit, looking for some financing and tentatively have some, it's got to go to REMSCO, but it is a potential at this point. I would like to, as we move forward, I'd like to develop a plan for regional skills nights in each county where all current, and we need to actually have our evaluators demonstrate their skills and their abilities to do a CME session via a scenario, so you get the critical thinking along with the skills. So have them apply, actually have them evaluated to see if we're comfortable, and choose who our list of CME evaluators are. I will tell you that we kind of got nonchalant where we weren't necessarily actually seeing these providers demonstrate their ability to teach skills via scenario. We were just taking the agency was just saying, we approved these folks and we were approving them. We weren't even following our own process, which was view them doing their skills. So these folks, have the application, have the approval process. This group, maybe a committee put together to approve who is and who isn't. Have an MOU with the region to provide 3 skill sessions per semester, 2 of which need to be evening or weekend. And dates need to be in place and approved by the program agency prior to the semester start for advertising. The new CME online site allows us a calendar where we could go plug those in. And folks would know, they could look up ahead of time and see, there's 3 sessions in Jefferson, there's, 3 in St. Lawrence and 3 in Lewis County, and there can be more than that. And then the evaluator will receive reimbursement on a per provider credentialed basis if they meet the criteria that's in the MOU. So if I wanted to say I was one of them, I would do 3 skills sessions, and I'm going to do 1 at Ogdensburg Rescue, 1 at Messina Rescue, and 1 at Canton Rescue, let's say. They're the ones that directly surround where I live. And put those on the calendar before the semester began. and I went and I had 5 providers show up at one, I'd get reimbursed for those 5. Now, if I just go out and say, oh, hey, I'll do your credentials and unpre-planned, I would not get reimbursed for those. But I will tell you that, this process needs to change, because I think we really need to start verifying the skills of our providers, and our CME evaluator list is out of control.
We also discussed that there will be a equipment mandated list that you have. We're finding that people are going and doing their skills and, oh, we don't have this. Well, just pretend you would do that. Just pretend you do that, and that's not a way to demonstrate your skills. So there will actually be a list of equipment that you have to have in order to do those stations, so that we can make sure that people are using the equipment and not pretending that they have it there and that they would use this or that or the other thing. And the other thing is, for tax purposes, no one will be able to exceed $600 in a year. Because when we get over 600, then we get into having to do W-9s and all this stuff. So we're going to keep it under 600 so that we don't have to play those tax games.
And obviously, we'll try and make sure that we find the appropriately qualified people and that enough sessions are in each county. We still have a significant issue, which is kind of an education, just an old school thing, where everybody automatically thought that 15 days that we gave the CME managers to submit our paperwork when you used to have to send it by mail became a grace period for the providers to do their CMEs, and that was never the purpose of that time. So we now have that 15 days after the semester ends. Everybody is frantically trying to get their CMEs done. They need to plan, prepare, and start to try and get their CMEs done. And managers and evaluators, you can do the CMEs, the skills portion, any time in the semester. It doesn't have to wait till December 31st. Really, it doesn't.
My feeling, a deadline's a deadline.
And then,
No, that's not
as
popular.
we start going through, but what happens is we go through and we send at a significant expense. It costs well over $3 and something, a certified return receipt letter, to each provider that just didn't bother to turn it in, but we're all done. So we send out all these suspension letters and then, turn around and...
Perhaps, as we discussed with RSI, perhaps it's time to switch the emphasis and onus on this to the agency to the agency itself. As an example, some regions have now, in Binghamton, you have the ALS coordinator, and they're responsible for CMEs, whether or not they practice, whether or not they independently practice as part of the organization. Because just because you're a random AEMT, there may be an in-house training program, and then they make the recommendation to the agency medical director, which is approved by the Remac, and tell the Remac, okay, this person is now cleared for in-house practice. Because a lot of what you're doing is realistically all in-house stuff that the CME manager should be managing for the service. That includes selection of preceptors, monitoring of preceptors, and so forth. And then if you find that they're pencil whipping stuff through, the agency's base is losing ALS. They'll do practice ALS. And that it's time. It's time that we shift. If agencies want ALS, or they want these specialty skills, they've got to take and put together a support structure in-house to make it work. Mark's going through this right now in blood products. Nobody here, Remac or the program agency offices, is making those decisions how to make that work. Mark is. Same idea with, a lot of these things. And I think perhaps you might want to consider retooling your whole work process, not the concept. The only other thing I know I've said this before, and I'll say it again. CME is a warm, fuzzy feeling for us sitting around the table. I'm not always clear that it's worth the time and effort we put in the clinical improvement of practice, because the end result isn't quantifiable. And you know, we've had a period where we went about 3 years up here with no CME system, and guess what? The quality, frankly, we had less call reviews than we got now.
That's just because we're not finding them, because we have another whole problem with our monitoring. Hence the reason why we push through these operating guidelines, where I will not do the part of those operating guidelines is I will no longer do the onesies and twosies cases that come in. I will start being able to monitor the system as a whole, because I think there are a lot of issues going on that we just don't know about. And frankly, it scares the, I'm going to say this, piss out of me. Sorry, John, that was...
I agree. And one of the other things that maybe makes some sense is focus on the QA committees, and let the QA committees not only review patient care, to view what's going on with CME. Just thought.
Well, and
because QA in a more global sense might get a better bang for your buck.
Correct, and that's why, I mean, with this system, at least ensuring that people have their skills and their this is easy. This doesn't take any time compared to what it used to.
Got it.
But because we only have 58% of our charts are electronic, or did I say that right, Kurt? I don't know, it's on the next slide, let me get there. One of the next slides. Anyways, it's hard to get data to look at the system overall. But we are working that way to do that, so.
I get it. But again, if the problem here is if we're having flaws in our educational standards, however you want to do it, we can't expect the program agency staff to be all places all times. And perhaps pushing some of this back to the agency and holding them accountable to, and by the way, I would offer that instead of maybe doing equipment checks for whether or not we let a service go ALS, let's look at their in-house QA system. Let's spend more time on the policy, procedures, and quantum analysis. Frankly, I won't say it's easy, but it's easier to go check the box at how many of these lidocaines I got and all that. But maybe it's time to start, the second half of that component is start doing the business process of managing the other half. Just a thought, not throwing that as a thought.
No, I agree. It's a good thought as well.
I just thought the way Lewis County did the CQI, where each agency had a representative, and we had the county meeting in the hospital. If they found a call, we'd bring it to the committee, and it would be, people would review it, and the person from that agency would not have a vote. We had a really good CQI process, and it was pretty active. I don't know if it still is. I'm not part of that committee.
Well, part of this is
And it
now
really helped identify things.
our focus, if you will, as this group, the governing body, to more than just the checklists of the physical equipment. We start asking the questions about the work practice and the management practices to really get a good handle on what's going on. We should know what percentage every agency is looking at for QA in this charts, the number of charts it's looking at. Should identify, and then take the same thing over. Okay, CME evaluators. How many do you have? How many students did each CME evaluator evaluate last year? Those sort of records, so then we can maybe look at some trends and figure some things out. I'll just throw that out as a shift in what we've traditionally operated in. It's a shift I think we need to make to start looking at these system issues.
Absolutely. So I guess I'm not sure what to do with poor James and Patrick, because, they did apply hoping to be approved, but if you guys are, interested in moving forward with this system, I would suggest that we table their approvals in hopes that we'll have the system out to you for review and up to vote and start in 2017, because that would give us the time to then invite them in, to accept their applications and invite them in for
I'll make the motion.
the skills demonstration.
I'll second it.
Okay.
All in favor?
Aye.
Any opposed?
Thank you. Medical director changes. Dr. Arenas replaced by Dr. Veith at Canton Potsdam Hospital. Yes, we had done this online because they were due to send in their recertification paperwork, and we were notified that Dr. Arenas was nowhere in the area, so it was kind of an emergency change, but I wanted to make sure it was noted here. DePaulville Volunteer Fire Department, they're a BLSFR. Dr. Maynard took over for Dr. Burris, who we found is their medical director still, who's retired. And then Carthage Area Rescue, July 1st, we just finished completing their change for their medical director to Dr. Pichelle. He since started practicing at Lewis County General. They notified me he was not going to continue as their medical director. So, any takers? Please feel free to discuss amongst the docs and let me know if anybody's interested after the meeting. They are also trying to scout on their end at Carthage to see if anybody's there, but I would certainly be happy to make a recommendation. If somebody's interested, please let me know after the meeting. So I would just do request a general motion to approve DePaulville and Colton on the public record.
Second.
All in favor?
Aye.
Any opposed?
Why is that not moving? So I received a letter from Constableville in Lewis County. They no longer have any practicing AEMTs. So they've asked to downgrade to BLS. Hammond Rescue in St. Lawrence County, they were a critical care. They have asked to downgrade to AEMT level pending or following an ALS inspection, and they do not want to move forward with putting the narcotics on. They only have one ALS provider. Madrid Rescue in St. Lawrence County is also requested to go from CC to AEMT, again because of the narcotic regulation, and they only have one ALS provider. So I would entertain a motion to accept those downgrades.
Motion.
In level of care. Or I shouldn't say downgrades, change in level of care. Excuse me.
Did we have a second on that?
Second.
All in favor?
Aye.
Any opposed?
All right, so there's a list of the pad that came through, as always, a notification. New York Air Brake updated, Purcell Construction updated theirs both in Watertown. SUNY Canton BLSFR did a public access defibrillation for their BLSFR team. At the last meeting, we reported on Morgan Stanley and Potsdam and Watertown. We were awaiting paperwork. We've received that. And we had one use report at Robert Moses State Park. Epinephrine auto injectors, the farm day camp, which I think is a cooperative extension day camp for the summer on Highway 68 in Canton. And albuterol, Colton Fire Department, because of their new medical director, so that was an update. We have a request for BOS CPAP for Waddington Rescue and Governor Volunteer Rescue Squad. So I would entertain a motion for approval of the update, but we already did, the BLS CPAP for Waddington and Governor.
So moved.
Seconded.
Do you have a question?
Yeah, I just was curious with the albuterol, I can't remember the name of the agency, go back one screen. The albuterol with, is it Colton?
Yes.
They changed their medical director. Did they also submit the changes in like their pad if they have that, or is I don't know if that's
Absolutely. We sent them a letter for every modality they had, and they've submitted all their changes, and they're working, and they're resending their CME program to Gene Myers as well.
Okay, so MDB form included.
Yep.
Thank you.
Yep. See, there's their Narcan. BLS blood glucometry, we received an application for Waddington Rescue. I would entertain a motion to approve pending the receipt, pending the program agency office receives their limited lab registration. It's in process. So approve once we get that paperwork. Okay.
Second.
So Narcan, Waddington, 3 Mile Bay, West Stockholm, BLSFR, Cape Vincent Ambulance, and again, Colton Fire Department updated theirs because they had the new medical director. So request a motion to approve them.
I make a motion.
Second, one of you guys? Okay.
This is an FYI, this is a Narcan report that was sent to the state for April, May, and June. Remember I told you I had wondered if the data was adequate from the few months before. It shows that most of the Narcan is still actually be given by ALS agencies here. So in Jefferson, you had 23 IMIV administrations of Narcan, 15 intranasal, 2 other because it wasn't, or they were IO, and 2 that were unknown because they were not documented. 4 out of all those administrations were done by were done in BLS agencies. So the data doesn't tell me that on those ALS agencies it wasn't a BLS provider that didn't do it. It doesn't break it down that far. Does that make sense? So that's the best I can give you. St. Lawrence, there was 8 IV administrations, 5 intranasal, 3 IO, 0 unknown. Again, all given by ALS agencies except 2, but that doesn't mean it's not a provider that was a BLS and an ALS agency. And Lewis didn't come up with any data. So this data was obtained from image trend and a scan of all the PCRs that we had, paper PCRs we had. We were finding that the documentation on the electronic side, they didn't always necessarily document it in a drop-down box, so it got pushed into image trend for a medication. And on the paper side, they didn't always check off that continuation form or put it where the medication should be put on the continuation form. It was just in the narrative. And we would happen to catch it, as, you know, because that word popped out at you. So I'm sure, yeah. I'm sure there was some more uses that probably were not caught, but this was a report that I had to send to the state, and that was the best data I could send. We've had a rather busy summer, by the way. ALS inspections, Lyons Falls, who was originally scheduled, they needed to reschedule, so I'm going there 9/29. I may grab Beaver Falls while I'm there that day. Norfolk's was completed a couple meetings ago. They were upgraded to paramedic level pending our inspection, and all that paperwork was done and sent to the state. So Harrisville, Star Lake, Cranberry Lake, Potsdam, Hammond, Lewis County Search and Rescue, Evans Mills, all have been inspected. No significant findings, with the exception of one that we've already talked about, and they're changing their level of care. Richville, ALSFR, I was scheduled to inspect them last Thursday. They requested a reschedule. And they are talking about getting narcotics, although they've been back and forth. The question was posed to me whether the ALSFR had to have it or not, which I did question Mary Ramo, and I did go in and look today with Dan at the requirements, and it is for ALSFR and for transporting agencies. I did put the little blurb in there about expired equipment because I promised an agency that I would bring it to this group. Previously, my belief was always if equipment was expired, it should be replaced because you can't guarantee the integrity of it. A couple agencies had come to me and said that they were told differently, that as long as they weren't yellowed, they weren't open, that they could keep the expired equipment on board, such as tubes, etc. So I promised I would bring it to this group for the Remac's opinion on that. And I have to wonder if maybe there was not some confusion back in the med shortage days, where when there was approval process to maybe keep meds on board after their expiration date. I know that I've talked to John since then, and honestly, I think that the body would be hard pressed to approve to keep expired equipment.
If it's expired, it's expired. That's the way I look at it, and they should come off the ambulance.
I just want to make sure that I didn't miss something or this group's intentions changed.
Do you want me to make that in form of a motion? I will.
If you want to, but I just wanted to make sure, and I told the agency I would bring it here.
I make a motion that if a piece of equipment or drugs are expired on an ambulance, it should be removed.
Second.
Okay, thank you.
Anyone feel differently? Okay.
Come on, Mark, say something I can tell. But I'm glad you will now.
I think one of the confusions, the education piece of this is, people say to me, well, now 4x4s are coming with expiration. The answer is yeah, that's the expiration of the sterility. And they don't understand that a lot of times it's sterility, it's not just, like, well, how can a 4x4 be expired? It's the sterility. And that's where this is. And again, there is one notable exception where the feds have said in this time of crisis, auto-inject pens, there's a relationship to that for nerve agent, for the national stockpile stuff. Other than that, there has never been any exceptions granted for using expired medications or expired medical devices in any way, shape, or form. And I think, today in our litigation world, you don't want to be going to court to explain that.
Actually, the reason there's expiration dates is that was required to sell in the European market.
Yeah.
And since I worked in this building for 30 years, and we made medical devices, and not here, but our other plant made the 2x2s and 4x4s, we started with two different HRI codes, one to sell European, one to sell in the US, and it became a nightmare trying to schedule it and maintain it, because we were on back order in one place and not enough the other. So industry-wide, all of the medical device manufacturers made the decision to go at the same time, go with one code and have everything with expiration dates.
Money for the longest time, students didn't have an expiration date.
2x2s and 4x4s never did, but now because of the European market.
not to, but they do now.
Yeah, European market requires that for selling there.
All right. Great information. Thank you. Huh?
Remember they made a
I made
motion
a
to
motion,
second
you
it?
want to call?
Yeah, she said
Does
anybody.
anyone have any?
Yeah, but we just, oh.
Okay, all in favor? Any opposed?
Okay. So, as many of you probably know, in July, agencies, it went into Part 800 that agencies, CC and paramedic agencies, had to have controlled substances. So I had gone through, and here are agencies without narcotics. Jefferson County's all set. Lewis, Beaver Falls, Lyons Falls, and Turin. I sent them a letter and requested a response in writing. I have had either discussions and/or with most all of these agencies. I have not gotten a response in writing from Turin Volunteer Fire Company, although I have heard that they may opt to change their level of care. I've not been notified that in writing, and but I received a written communication that Beaver Falls and Lyons Falls are going to pursue getting their Class 3 license. And St. Lawrence, Herman, their plan was approved, and they weren't on my list, but their plan was approved, but their safes were never inspected, so I sent them a letter to find out the status, and I was brought, I was at another meeting, and I was brought their certificate, their license, and said, here. And I said, so you're telling me they're on board? And they said, yes. I said, your safes weren't inspected. And I said, okay, we have to talk to John, so put that on your list of we have to talk to John things.
Last I knew, everything we had on them was 2 years old. And they got a license out of Albany, okay?
I wasn't aware they had an ALS provider.
That's the other piece.
They have one ALS provider.
Is minimally existent.
That's a good way to put it, Mark.
Yeah, and there was a whole bunch of other, and they're on our list. They're on the list I gave you. So I'd be curious what that license is. I've not seen it.
I have it somewhere.
All right, we'll figure it out. Let's just put that, we'll talk tomorrow. Okay, but that one, last I knew, was a whole holdup with that, and then I sent back stuff because it was 2 years, and I said, I'm not buying signatures that are 2 years. Well, I'll say it was 18 months. It wasn't like, it was maybe not 2 years, but it was a ways back, and I just said, no. And then, I don't know what's happening after that.
I have attempted to set up an ALS inspection with this agency multiple times to no accord, so I really don't know what they have or do not have.
And they've not responded to my letters either.
So, did somebody have a comment now? Okay. Anyhow, DeKalb, Richville Fire District, ALSFR, they seem to want to put narcotics on board, although we've had multiple discussions, and I'm not 100% sure which way they are going right now.
They are moving forward with it as of today.
Okay,
Or at least attempting to. That is their way.
but again, I just recently had a discussion with them because I have not done their ALS inspection, and the reason why it was rescheduled is because they had drugs that were out of date that I just happened to see as they opened the drug bag and were looking for a atomizer for me when I was doing a BLS training there. Anyways, moving forward, Hammond Fire and Rescue is changing their level of care. Madrid is changing their level of care. Norfolk Volunteer Rescue was on my list. They had gotten their license. They're awaiting safe inspection, is what I'm told. So maybe, John, we have to talk about that. But their narcs are not on board. But they have their license, and it came like right before that list came out. Rensselaer Falls didn't have narcotics on board, but they had completed an application. I just happened to find out about that in passing, but they do now have their narcotics on board. Huh? They're okay, but they had a delay in getting their narcs on board. They do have them on board now.
They have a license issued for a couple of months.
Yes. I think that was it on my list. I had sent all that correspondence back to the state, but what I would I think that this body needs to have a drop dead date that this needs to be compliant by, and that we need to continuously follow these. I mean, we should help them if their if their paperwork is being hung up on red tape or on somebody's desk. But if they are not moving forward with getting this done, they have had a long time to do this. It's been coming for a long time.
Has the state issued a deadline date?
The only thing I would recommend is at the state council meeting, Lee Burns herself said that for the remainder of this year, the state is going to take the stance of continuing to guide and assist in the process, but that more than likely come 1/1, the state will reach out to the regions for enforcement.
And I think we should just take the bull by the horns and set a drop-dead date unless the agency can show us that they're working towards it, because this is what happens from my perspective, is I work with these agencies and they don't follow up on their end of the deal. And we can work with these agencies for months and months and months. If they aren't done, they have to change their level of care until such a time that they do complete it and upgrade their level of care. Back to agencies taking the responsibility, and it needs to happen.
I make a motion that we have a drop-dead date for narcotics for those agencies that do not have a license, December 31st, 2016.
If their paperwork has to be submitted by then?
Yep.
And if they don't?
They don't do ALS.
They have to be dropped back.
They drop back. That'll force them to put in the paperwork.
I'll second the motion.
We go to discussion.
Mm-hmm.
I'd like to point out, not to disparage what.
I know, John. I'm waiting for it.
It is, Lee, I believe, did not say January 1st was the deadline.
No, that's what he said.
She said at that point they would look at reaching out. Look at reaching out.
More proactive.
More proactive. Assessing the.
I'm just trying to be proactive, John.
I don't know.
And you have that authority.
You have the authority to do that. I'm not.
That's what he said. That's what Dave said.
I want to be very clear here. We as the Department of Health have not set a 1/1 deadline.
Yeah, no.
Okay, just for this discussion. That data, because that's kind of what you said, I think.
I apologize because
That's not how I took it.
My point was that Lee had mentioned that come 1/1 that they were going to, and I used the wrong, she said proactive, but she was going to look at reaching out to regions
Dan and
for.
I here, I just need to be clear about that, because we would not be disappointed if we didn't make that clear.
No, she didn't say that she would mandate it then. She was going to look out to regions.
To figure out a plan.
Okay, so further discussion on the motion that's put forward.
Why are we going 1/1 of 16 if the state is not even established?
Be 17.
No, he said December 31st to 16.
I just think that they've had plenty of time to get the application, the paperwork in. We should set a deadline date. This has been going on way too long.
I agree. I think regulatory issues aside, it's going to be 2017, and when one receives advanced care, it should come with analgesia.
Yeah.
I mean, crank back the clock 27 years ago when I first got into EMS, you give people a stick and told them to bite on it, but it's 2017, and our patients deserve pain management.
We should be
And to me,
protecting them.
To me, that's more about what this is about than the regulatory part to that. So I completely endorse the motion personally.
Thank you, Mr.
Other
Tuttle.
comments?
I can tell you I was opposed to having to get narcotics when we started this process, but the paperwork has not been difficult at all. The semi-annual reports have not been difficult. The hospital is working, and Jefferson County is working with all the agencies, sets up a time to come in for the inspection, and it's not been bad at all. And we can certainly do the same thing in St. Lawrence County that we did in Jefferson. I had John here. We had every agency come in. We had a notary here. we can make all that available again and get people through it in one night.
And if I may point out, during the process of consolidating.
Not leading the paperwork.
So that it'll be easier to do the quarterly or biannual reports, depending on what meds you're carrying. And hear me, the minute we get one of these, okay, now we have myself here, as we get these, if I get two of them in St. Lawrence County, we'll find something else to do, but we'll get up there, literally not weeks, like days, to get them done and get them in, because we understand the priority here, and I want to strike while the iron is hot, okay? I mean, I won't drop everything, but I don't want these to sit weeks. I want them to be done, within a few days. I don't want to make one trip all the way north for one agency. I would do a couple, but you get my drift here. And if there's any hassle here, paperwork-wise, as an example, this list, and Ann and I have had multiple phone conversations about this, okay? If there's hassles with this, we'll figure it out and we'll get it squared away, whatever it is. Okay, from our side of the department, I gotta have paper to react to, and a plan to look at, and review and comment. And yes, we have to do physical inspections, but our intent here is to be as customer service oriented and helpful as we can be about this. That is our intent.
Dan.
I know you hate seeing my smiling face, but sorry.
All right, Dan, you have a comment?
Just to ask for clarification on Mr. Beaver's motion. When he said control substance application submitted, did he mean at least to the DOH regional office?
Yes.
Okay, thank you.
Okay, so is there further discussion on the motion? Okay, all in favor?
Aye.
Any opposed? One opposed? Are you opposed, Ken? Okay, so one opposed.
One opposed. Did you get that, Kurt? All right, moving forward, here's a list of our EPCR agencies within the region. Again, 58% of our PCRs are still paper in the region, which makes data collection difficult. Town of Watertown Ambulance actually submitted an MOU and switched vendors to Ram AIM. And Guilfoyle, Star Lake, Wellesley Island are currently in process, and we hope to have them up and running soon. And once Guilfoyle goes electronic, that should change that bottom number greatly.
Yeah.
Training for Spring Fling, Debbie has secured Steve Berry for next year as our keynote and to do presentations. We'll be incorporating some of the local instructors to complete the core content programs. I completed the following trainings. Colton Narcan was completed, Star Lake, Carthage, some BLS CPAP training. Richville, I went and did some BLS blood glucometry and Narcan training. Upcoming training that I have is Briar Hills reached out to me to do their check and inject training on the 29th. Just a quick report, and I didn't get to finish this slide before I had to come over. They did a report on the check and inject program at the state meetings. There's 476 agencies enrolled across the state. There was 32 administrations. The North Country was mentioned because the data that was pulled from Image Trend for 2 years, which I'm believing is an error, we haven't gotten to dig into it, showed over 200 uses of EpiPens in the North Country region alone. I believe that was an error. There is only like there's only like 100 and I don't remember what they said annually, 130 some uses annually across the state. I think it was, but I don't remember the exact data.
Ken said we had an attack of killer bees.
Yeah. That came from Kurt. Anyhow, basically though, they did approve for the demonstration project to continue, right? The SEMSCO did approve for it to continue until such a time that the Commissioner of Health makes a decision in regards to the program. So that's where we are with that. But they had 32 administrations. They did find some need for there was a huge discrepancy between their pre and post tests, so it did show that there's a current weakness out there for the identification of the differences between allergic reactions and severe and anaphylaxis. So, that's all I have for my program agency report, I believe.
New business, narcotics.
Already taken care of.
Beautiful. Does anyone else have any other new business?
The proposed schedule, it follows REMSCO unless anybody has any objections. I apologize, the February date, beginning, the first Monday is a holiday, the second week is state council, the third one's a holiday, and the fourth one, I'll be basking in the sun, so I won't be here. So we were looking at going to February, if that was okay with everybody. The assumption is we're going to have a meeting in November anyways because of the CON, so.
We know exactly when yet?
No, when Ron gets here, we can get a better idea. But we were hoping to move on that and have a vote in November on that. Get the public hearing and.
We will send notification out as soon as we know. Unless you guys just want to schedule a meeting.
It's kind of hard, really, because you don't, I mean, you got to follow that timeline.
I know.
So, I mean, we could make a best guesstimate, but it'd be kind of hard to set a meeting.
I'm just trying to get one as soon as possible, because I make the schedules for our ER. And the last two meetings I missed because I had to fill in for somebody like that, so.
Well, we normally do them on Monday nights, so take every Monday night off.
Yeah. Woulda, shoulda, coulda.
So do we need a motion for that? No.
Any other new business?
I make a motion, we adjourn.
All in favor? Adjourned.
CQI? Yes?
We can have a brief
Okay, we need a
discussion.
brief.
I don't know